All right, plus right. Test 1, 2. Test 1, 2.
Can you confirm my sound is working?
General floor session voting was more prolonged than as anticipated. So pushed everything back here. Appreciate everybody's patience. And so let's call the meeting to order. And Senator Setzler, would you mind opening us up? Floor session voting was more prolonged than as anticipated. So pushed everything back here. Appreciate everybody's patience. And so let's call the meeting to order. And Senator Setzler, would you mind opening us up? Floor session voting was more prolonged than as anticipated. So pushed everything back here. Appreciate everybody's patience. And so let's call the meeting to order. And Senator Setzler, would you mind opening us up? Floor session voting was more prolonged than as anticipated. So pushed everything back here. Appreciate everybody's patience. And so let's call the meeting to order. And Senator Setzler, would you mind opening us up? Floor session voting was more prolonged than as anticipated. So pushed everything back here. Appreciate everybody's patience. And so let's call the meeting to order. And Senator Setzler, would you mind opening us up? Floor session voting started.
Okay, we have 3 bills and we have an hour, so we're going to need to keep moving. And Senator Watson, you want to go ahead and present your bill? Your mic is on.
Sure.
That's
Thank-
Senate Bill 30.
Senate Bill 30, thank you. Just take us back historically. Senate Bill 140 was a bill that was done 2 years ago, and that forbid surgeries on minors for gender dysphoria. And what the bill today is the exact same bill that we presented last year to this committee, passed out of the Senate, and did not make it through the House. And
Pull your mic towards you a little bit. So here.
This adds the puberty blockers, forbidding those to be used in minors for gender dysphoria. Taking you through the bill is, the first part is for institutions and the second part is for providers. And that's it in a nutshell. What I'd like to do, if we could, would be to have Dr. Michelle Zena, who is a pediatrician, let her give her expertise, but she does autism for the state of Georgia and in private practice. And she testified last year, so if we could allow her to testify and then go from there. I think we did decide time limits on this. I know you had to be somewhere at 5:30.
Yeah, because of the schedule being delayed, there are several of us that have other committee meetings at 5:30. And so what we're going to do is we'll see what questions the committee has, and then people are going to have to figure out how they want to split up the time. We're going to have 10 minutes for each side. And so if people are repeating the same thing, you probably don't need to do that. So with that, Dr. Zena, are you there?
Yes, ma'am.
I can't hear her.
Yes, ma'am.
Yes. Okay, are you there?
Sound check, sound check.
Yes, we can hear you.
Thank you, Dr. Kirkpatrick, and Chairman Watson for this opportunity to share my concerns. As Dr. Watson said, I'm a pediatrician who focuses on caring for children with autism. Check, sound check.
Yes, we can hear you.
Thank you, Dr. Kirkpatrick, and Chairman Watson for this opportunity to share my concerns. There's a 30-second delay. I'm a pediatrician who focuses on caring for children with autism. Check, sound check.
Yes, we can hear you.
There's a delay. Thank you, Dr. Kirkpatrick, and Chairman Watson for this opportunity to share my concerns. There's a 30-second delay. I'm a pediatrician who focuses on caring for children with autism. Check, sound check.
Yes, we can hear you.
There's a delay. Thank you.
What are you doing?
Is the loop fixed?
Still there? Can you hear me? You want to take questions from the committee while you wait? Do you want to take questions from the committee while we wait, or do you want to wait for Michelle? Okay, let's try again, Michelle.
Is this
Yeah.
a loop? Are we good, Dr. Kirkpatrick?
Yeah.
Excellent. Thank you. I appreciate this opportunity to share my concerns. As Dr. Watson said, I'm a pediatrician who focuses on caring for children with autism. I also care for children with anxiety disorders, complex ADHD, and tic disorders. And youth with autism are much more likely to experience gender confusion or identify as LGBTQ in some way. So this is an issue that's close to my heart. And for perspective, in Georgia, if you're under 16, you cannot consent to have sex. If you're under 18, you cannot consent to have a tattoo or a genital piercing. Most OBGYNs don't think young mothers under the age of 25 can consent to having their tubes tied to prevent additional pregnancies. And I don't understand why anyone would think it's a great idea that children can understand and consent to permanently altering their body. They're not capable of making life-altering decisions. We require them to attend school until they are 16. We don't leave them at home alone for the weekend. And when we have young people who struggle to label their own emotions, and I encounter young people that can't label their emotions every day. And some of them are very smart students who make excellent grades, qualify for gifted programs, but that doesn't mean that they understand their emotions or that they can convey abstract concepts or understand abstract concepts. They also really often have difficulty understanding the perspective of others. And those deficits really impact their own sexuality and their relationships. So allowing children and adolescents to make decisions that are permanent doesn't really seem in their best interest from my perspective. We do a lot to protect children. And I think we need to be protecting children who have gender dysphoria or gender confusion as well. As adults, we're obligated to nurture and guide and protect them.
Is that it?
I'm happy to answer any questions, especially related to autism and children with autism in this bill.
Okay, so stop the timer then. Okay, so questions from the committee for Dr. Zena, and then we'll let her get back to seeing patients. Okay, thank you, Dr. Zena.
Thank you.
Hang on, don't leave yet. What's your mic number? Okay,
Are we in, can you hear us?
Yes, ma'am.
Yeah, I'll move the microphone. Thank you for sharing your remarks with the committee. We were optimistic that we might get the opportunity to be sure that there was therapy available to as you described, the role of therapy and engaging with children and young people, minors, and those with gender dysphoria. And we did try to get that in a bill that was before us the other day, and which I think would have improved the bill. But I would assume that from your remarks, you have a keen understanding of that therapy relationship with young people as they try to sort out all the things that they're faced with.
are you asking Dr. Zena or the author?
Oh, no, I know, I'm looking at they're both in my, I was asking our presenter. The woman who just spoke, the doctor who just spoke.
Dr. Watson, do you want to handle the questions and let Dr. Zena go back to work, or was there
Oh, well.
something?
I mean, I'll be happy to address that question. I don't think anybody here in this room would not think that that mental health counseling should be part of this plan. It should be the initial part of the plan, and that the bill you're referring to, I don't think Dr. Zena has knowledge of
I
that.
understand.
And I think the author pointed out in that bill counseling, and that language probably does need to be tweaked and addressed. And I think we're in full agreement on that.
Thank you.
Thank you. Okay.
Autism with
What's your mic number? Okay,
I don't see the autism provision. What is tell me what is about autism. I just don't understand. You mentioned autism, Madam Presenter, Doctor.
What's the question now?
She mentioned something about autism.
We wanted to ask a question about autism.
Do you have a question related to?
What does this bill have to do with autism? Madam Presenter.
Yeah.
Children
Dr. Zena?
children with autism are much more likely to experience gender confusion, gender dysphoria, or identify as LGBTQ.
And is that
Yes.
addressed in this bill?
No, that's where my expertise comes from. as someone who cares for about 1,000 children with autism. So I see lots of patients that this bill would impact.
Okay, any other questions for Dr. Zena? Thank you for being with us.
Thank you.
And further questions from the committee for Dr. Watson? Yep.
I have a couple. I'm 12. Couple of questions.
Yeah, why don't we do this? Why don't we just do testimony, or I'll defer to the chair, but if we can do testimony from both sides, if that clarifies some questions, and then I can wrap it up if you'd like for me to. Is that okay?
That's up to you,
Are you okay with holding your questions
see
until
if
we
it
hear
gets
the public
answered in-
testimony, and then we'll answer everybody's questions
That's
at the
fair.
end? Thank you. Okay, so we've got a number of people signed up for and against, and you're going to have to use your time wisely. So we've got 8 minutes left for people who are in support of the bill. And the first person that I have listed is Mike Griffin. If you want to go to the podium, Mike, please.
Thank you so much, Vice Chair. I appreciate the opportunity. My name is Mike Griffin. I'm the Public Affairs Representative with the Georgia Baptist Mission Board, and we would like to thank Senator Watson. We do support this legislation. Georgia Baptists support legislation that bans medical gender transition procedures on minors. Also, Mac Parnell, who is Executive Director for Georgia Faith and Freedom, supports this legislation. He's not able to be here as well. We passed a resolution as Georgia Baptist in 2019 on gender dysphoria and its treatment. We represent approximately up to 1.4 million Georgians and 3,500 churches. And so we believe that regarding gender dysphoria, that there needs to be more of a focus on education, protection, and mental health counseling. And we believe that many of the gender dysphoria issues that we're dealing with today are driven by culture rather than biology. And so we do appreciate the senator again, and we appreciate the committee's favorable support of this legislation. Thank you.
Thank you. Dr. David McKillop?
Thank you. I was hoping to go later on after others spoke, but do you prefer me to go now?
Yes, and we have
Thank you.
6 minutes left.
Thank you. I'm Dr. David McCaleb. I'm a neurosurgeon in Cartersville. Been practicing for 27 years. Been in medical school, started in 1987. Been around in medicine a long time. Let's clarify, puberty is not a disease. Puberty is a natural part of humanity that has to be experienced, not treated with medications like a disease. I hope you'll vote yes on SB 30 and give kids a protection against puberty blockers used to stop natural puberty and gender dysphoria. And we need law to do that, not through the Composite Medical Board. I represent many doctors who know it is completely unethical to stop natural, normal onset of puberty, especially in kids with gender dysphoria. I'm also active in the Republican Party and Republican Party platform at the state. Through citizen activism, changed our platform to assure that we oppose the use of puberty blockers for gender dysphoria in kids. Kids need protection of puberty blockers under the law now. Puberty blockers and gender dysphoria are not reversible because they're used for years. When you shut down puberty for years, there's no going back. There's no ethical practice of medicine that can support stopping the natural sexual development of kids. The only reversibility comes when you use it for things like precocious puberty for a year or two, but not for when you stop it for years. Kids on puberty blockers for gender dysphoria are more likely to go on to use dangerous cross-sex hormone, the vast majority do, and move on to pursue cross-sex surgeries. Without puberty blockers, the vast majority of kids with gender dysphoria identify as their natural sex in young adulthood. A third of those on puberty blockers lose bone density, stunt their growth. Most, if not all, lose fertility when you stop puberty naturally in childhood, and they never experience normal sexual function if they regret it later, having stopped their puberty. It's been known to decrease cognitive development, and there are side effects from medications used this that include seizures, brain swelling, and visual loss as possible side effects. The medical literature shows there's no decrease in risk of suicide by using puberty blockers and cross-sex hormones in the gender dysphoric population. The data is quite clear on that, and you have copies of that. Transgender adults, however, have a suicide rate still 19 times higher than the general population despite all these treatments. They've stopped these in UK, Sweden, France, and Denmark. There's just no way to ethically give these kids these hormones. Many doctors and hospitals earn significant income. There's a group called QueerMed that's based in Georgia that offers this, according to their website. Feminist Women Healthcare, I know, is here today. And there are kids that are referred out of state after starting puberty blockers here. They're referred out of state to get these things done. And if it wasn't being done in this state, would there be so many people here today to oppose stopping puberty blockers? So I hope you're not dissuaded by what will likely be a lot of emotional arguments, claims that there's a nuance or that there's some rare exception we need to address. All this is addressed in your bill. I hope that you'll pass this. I hope that you'll carry it in the Senate, get it passed before crossover day, and hold it to the end when you get into conference, if it's an issue, as a top priority, because our kids need to be prioritized and all the politics that happen here in Atlanta. Thank you very much. Support 30.
Thank you. Chelsea Thompson. And you have
How
a
much
little
time do I
under
have?
3 minutes.
Chairman, okay, thank you. All right, so my name is Chelsea Thompson. I'm General Counsel, Frontline Policy. I had the privilege of working on the language with Senator Watson on this bill. We support the bill, and just from a bird's eye view to kind of take it back really simply, this is about, we were talking about minors permanently altering their body with the use of puberty blockers and hormones for the purposes of sex transition. And I would like to encourage you to look at, I was going to have a testimony, but I honestly would like to encourage you guys to look at an article, if you haven't seen it, by Dr. Kautilala. She's from Finland. And the article is entitled, Gender Affirming Care is Dangerous. I know because I helped pioneer it. My country and others found there is no solid evidence supporting the medical transitioning of young people. Why aren't American clinicians paying attention? As the doctor mentioned before me, the UK has closed the world's largest pediatric gender clinic in the UK, and governments and medical academic institutions in Sweden, Finland, and Denmark have rejected prioritizing gender transition in favor of emphasizing extended mental health evaluation and support. Over 70 gender clinics across the United States have closed down and recommended further research in the mental health area. And then desistance is the norm for minors with trans identification, with about 85% as an average desisting as they grow up. By adulthood, and 21 other states have passed legislation prohibiting puberty blockers for the uses of sex transition or attempted gender transition, and so we would ask that Georgia would do the same. Thank you so much.
Thank you. Okay, now people who oppose the bill, starting with Dr. Jason Schneider. And just keep in mind that there are a lot of people that want to speak, so please keep it short.
Thank you, Dr. Chairwoman. Yes, I'm Dr. Jason Schneider. I provide gender affirming care to people in the Metro Atlanta area, and I'm a national expert in this area of medicine. I'd really like to see the literature that the previous speakers have cited because there is evidence that was published this year, a longitudinal study of youth here in the U.S., not even in Europe, that have showed improved mental health outcomes for people that receive gender affirming care. And contrary to what you've heard, puberty blockers, the effects of puberty blockers are totally reversible. So I'm not sure what literature they're citing. I really would like to see it. Additionally, to refute what was said earlier, there is no evidence that co-occurring mental health conditions cause a person to adopt a trans identity, nor is there evidence to support that treatment of co-occurring mental health disorders like autism ameliorates the core symptoms of gender dysphoria. So each of us as physicians take the oath of Hippocrates, and we swear that, among other things, we will practice non-maleficence, or first do no harm. Senate Bill 30 would in fact cause harm. Restricting prescribing for transgender youth as proposed goes against the current scientific evidence. Furthermore, the mental health consequences for trans youth that will occur because of this proposed bill are quite severe and entirely preventable. Prohibiting healthcare professionals from providing necessary and life-saving treatment to our trans patients is a stark example of government overreach and directly challenges our professional responsibility to prevent harm and reduce suffering for those entrusted in our care. Many of you on the committee know that we face a shortage of healthcare providers and physicians in this state. Laws that restrict healthcare professionals and physicians from practicing evidence-based medicine will further exacerbate this problem. Criminalizing medical care is not going to attract physicians to this state. The Hippocratic Oath also demands that we as physicians humanize each of our patients, not treat them solely as statistics or political targets, as this bill does. Transgender youth and their families should enjoy the protections of personal freedom and informed choice that are core values of our state and include decisions made in healthcare settings. Thank you.
Thank you. Elizabeth Downey.
My name is Elizabeth Downey. I'm speaking in opposition of SB 30. I was born and raised north of Atlanta, where I now reside with my family. I'm a University of Georgia and a Mercer University graduate. I'm also a licensed registered nurse in the state. It is alarming to me that so many legislators, including the 30 that sponsored SB 30, none of which are endocrinologists or specialize in gender dysphoria, feel that they can ignore decades of research and data on the subject of gender dysphoria and implement laws year after year targeting transgender people. What makes you think you know what is best for someone who is transgender? Seriously, what? Because you are a legislator, possibly an attorney, possibly a physician in another field of medicine? Well, I'm here to tell you, you know nothing. You aren't protecting minors, but what you are doing is harming them at an alarming rate. I'm sure some of you are diabetics, have hypertension, ADHD, or an autoimmune disorder. Maybe you even know someone who has cancer, even pediatric cancer. I'm also sure the majority of you or your family members who have those diagnoses seek medical care to guide you and help you manage your symptoms and provide medicine to improve your quality of life. So if you seek treatment for those, why do you feel the need to stop minors from seeking care for gender dysphoria and threaten the very providers who have devoted their careers and are following the most up-to-date medical protocols? You see, I'm not only a nurse, but I am a wife and a mom to 2 girls. One of them is transgender. I remember my pregnancy like it was yesterday, her birth, all the amazing, joyful, and tough years that have followed. Because at age 3.5, something was different about her than my friends' kids or my nieces or nephews. She loved to twirl, sing, and dress up in dresses. Her dresses were oversized t-shirts or tank tops. She hated sports, despite her dad and I being tremendous athletes. She also never wanted to play with boys in her preschool or early elementary school classes. She wanted to be the male. She never wanted to be the male and pretend play, always choosing to play the female or mom. This went on for several years until she found her voice to express who she was on the inside. She socially transitioned at age 7. Again, you all say you are protecting children like mine, but until you live the life of being trans or raise a child who is transgender, you are simply clueless. We aren't mutilating our children's bodies. That would be parents who consent to have their newborns circumcised. We aren't sterilizing our kids. That is the children who unfortunately have to undergo radiation and chemotherapy for pediatric cancer. What as parents are doing is loving and supporting the child that God created in his perfect image. That means seeking specialists in the field, following the most up-to-date medical research and protocols, and at the appropriate ages as their peers, possibly providing puberty blockers and later starting hormone therapy. Every transgender person's journey is different. It's horrifying to imagine as her mom, my daughter, being forced to go through male puberty now, when she has lived her life authentically longer now than how she was identified at birth. Thank you.
Thank you. Okay, we have about 4.5 minutes left. Peter Isbister and then Brooke Rappaport.
Thank you and good afternoon, Mr. Chairman and members of the committee. My name is Peter Isbister. I'm the founder of Metro Atlanta Transparent, a parent support group for parents of transgender children that has a membership roll of close to 200 families. I'm the president of the board of directors of Congregation Beit Havarim, a local Jewish synagogue, again with about closing in on 250 families who are members, and I am my transgender child's parent. You are all here in part because you took an oath to uphold the state and national constitution and to provide for the interest and the prosperity of the state. I am here because when the history is written, I want to be able to tell my child that I was here. 4 years ago, or 2 years ago, when we did Senate Bill 140, the entire Republican Party told us that they were only interested in hormone replacement therapy and not in puberty blockers because puberty blockers were not permanent. That, of course, is not turned out to be the case. You are also, I would argue, not here because the Constitution calls upon you to be in loco parentis at all times. I do not need, the parents here do not need anyone in loco parentis. The parentis is here. My 11-year-old son will get the health care he needs, I am privileged to say, because I will go to the ends of the earth to make sure that he does. Why? Because I love him, as you love your children, because our love is not different than your love. My family has graduates of the University of Georgia. I take my child to Cub Scouts. Have been a member of the PTA. My child plays tennis. He goes on sleepovers. He goes on field trips. We go to 2 houses of worship. Do you trust yourselves to provide for your children's health care? I would imagine that you do. Do you trust yourself to love your child and teach him and show him or her the love of God as we do at Congregation Beit Havarim, where we believe that we are all in the image of God? I am sure that you do, that you trust yourselves. I am asking you to trust me and to trust us, because we are not different than you.
Thank you. Brooke Rappaport, we've got just under 2 minutes.
Good afternoon. I'm happy to be here today. My name is Brooke Rappaport. Sometimes I go under Brooke Mills. Fun working with a middle name just because the last name is so hard to pronounce. So I'm happy y'all are actually letting this discussion be had, as opposed to last year where it was being snuck in at the last minute and having an absolute chokehold on the constituency process. So I'm glad y'all are opening up to this here. Now, I have to point out, what the hell was with all of these damn radical anti-trans activists here? I mean, none of them treat gender dysphoria. None of them can talk about having treated a transgender child or adult. And in lieu of what happened yesterday on the Senate floor, it is obvious that that none of this is in good faith. Every single Republican in here voted down a measure that would allow just the damn basic mental health and behavioral therapy for transgender Georgians, adults. Because heaven forbid, once y'all strip away our health care, that we're too damn suicidal that we need to see a therapist. But apparently, screw us in particular, because it's obvious that y'all are trying to eliminate transgender Georgians. And I know what a damn eliminationist rhetoric looks like. My family came from Poland and Russia. We survived the Jewish pogroms against us. We survived the fucking Shoah, and we know.
Your time's up. Thank you.
Your predecessors tried.
Okay, that's all the time we have for testimony. So we're going to take questions from the committee to the bill sponsor now. And I think Senator Merritt, you asked first.
Yes,
So
ma'am.
go right ahead.
Thank you, Madam Chairwoman. Mr. Chairman, how do you respond to the studies? And we've been hearing that showing that restricting gender affirming care increases rates of depressions. We are talking about saving kids and we're concerned about children, but how are we responding that if we do restrict the gender affirming care, how are we responding to the rates of depression that could be caused by that?
I'm sorry.
Thank you. Now, first of all, no one is denying treatment for mental health issues relating to that. Absolutely. I think everyone here in this room, as I said earlier, certainly would encourage that. Physicians would encourage that. All the LPCs, all the parents, all the social workers, psychologists, psychiatrists, primary care, pediatricians, and the accepted way that has been done, primarily led by the countries that you said that was said by a speaker, the Sweden, Denmarks, and Finlands and UKs. That is the first way. That is the way that should be and is done and should be strongly encouraged, mental health counseling. To reference your study that yesterday and in others, the collaborative whole picture related to that. There is no evidence to show that there is an increase in suicidal aspects or doing without it or with it. I mean, the fact is that puberty blockers have a major side effect. I mean, every pediatric endocrinologist that has used this in the past, they all put them on vitamin D. They all put them on calcium. Why? Because of osteoporosis in young people who have those hormones denied. If you look up the serious reactions and common reactions related to puberty blockers, you'll see that the serious reactions is the whole list is long. It goes hypersensitivity, anaphylaxis, Stevens-Johnson syndrome, toxic epidermal necrolysis, eosinophilia, hepatotoxicity, bone density loss, as I was just mentioning, and suicidal tendencies. So yes, that is one of the serious adverse affects relating to the puberty blockers. And my list, that's just half the list of adverse reactions. And then the common reactions: hot flashes, sweating, tumor flare, hormonal flare, headache, sleep disturbance, vaginitis, general pain, depression, again, emotional lability, testicular atrophy, urinary disorder, edema, constipation, diarrhea, injection site. The list goes on. That's about half the list also. And now I can go on further, and I will in my wrap up, but I think that
May I have follow-up questions?
certainly.
Okay, so I'm still trying to get to, and where is the data that would show that when we restrict care, it does increase rates of depression or does not? We don't have any comparison for that. I don't know if it's in.
The
any of
British
the-
Medical Journal, as I had cited with SB 140 and last year, did a huge review. There is no real good data when it comes to evidence-based medicine that the previous physician had mentioned. No accepted evidence-based medicine to show this does good. And the lack of puberty blockers, it is a mental gender dysphoria. Certainly, the first treatment is for mental health counseling.
I just have one more question, just one
Okay.
more. I'm concerned about how we're going to enforce, and how will this bill be enforced? And what penalties will healthcare providers face for violating this law?
Yeah, as Chairman Tillery and Senator Chairman Kennedy did with SB 68 and SB 69. If we go back to the bill, if you look on line 60, that's for institutions. That has to do with that perspective, that aspect related to DCH. If you look on line 123, the licensed physician who violates this code section shall be held administratively accountable to the board for such violation. And that's the Composite Board of Medical Examiners. That's all the way from restriction of license to losing your license.
Other
Thank you, Mr. Chairman.
questions from the committee? Okay, Senator Harrell.
Yes, so I think everybody on this committee probably supports evidence-based medicine. There is a lot of confusion about the research that's out there. I first, when the doctor with the white coat, I failed to get his name, who testified. He referred to a longitudinal study that showed positive outcomes from the treatment. And I'm just wondering, Mr. Chairman, can we ask him how long the longitudinal study was? Because I'm not very familiar with any longitudinal studies.
To defer to the.
No, he's
There he
here.
is. Okay. Can you answer that question about how long the longitudinal study was?
I can pull the reference, 3 or 4 years at least. And again, this is US-based data from centers in the US, not from other countries.
Can you tell us what the age of the participants were?
So,
You probably should go over to the podium if you're gonna.
sorry,
Over to the mic.
wasn't expecting to be called on, but happy to.
Understood.
And I can pull the reference for committee staff if you'd like to know, but I believe this started at ages before puberty, when often concepts of gender identity begin. So does that answer your question?
Thank you.
It actually raises more questions.
Well,
but
if-
we can talk later.
If you want to send us.
The quality
something,
of-
It
yeah.
won't help with the committee
The
today, but we can
quality-
get it for people to review.
Yeah, the quality of the scientific research is really important.
Yeah, I mean, and she's exactly right. The quality of the research on this is not as good as we would like it to be. That's been a challenge for the whole community.
Thank you. Thank you, Doctor. Senator Oraki.
I would love to see this.
Yes, I haven't thanks.
seen any longitude.
Thank you, Madam Chair. To the author of the bill, why do you think that the American Medical Association, the American Academy of Pediatrics, the Federation of Pediatric Organizations, and the American Psychological Association support access to evidence-based medical care for transgender young people and adults?
Yeah, I'm not in disagreement that they need care. I think that is absolutely true. I think mental health counseling is the first way to do that. You know, one of the physicians, maybe just the recent physician said, do no harm. And that's what our goal should be. Puberty blockers do harm. And that's the issue. It changes the bone structures. It changes so many things. It blocks a natural response that youth are going through. They're going through puberty. These are puberty blockers. Is a natural process that they go through.
But 300 doctors here in the Atlanta area have signed a letter that I'm sure most of you have seen.
I can get the same thing with social workers, LPC, psychologists, psychiatrists, and other organizations too. And the whole states of Sweden, Finland, Denmark, and then the UK also closed their clinics, and they're not doing any more puberty blockers there. And you heard, I didn't realize it was up to 21 other states are doing that now. I agree. We are lagging behind in the US with this.
Well, that was not what I indicated, that I don't believe that.
I understand.
You said you agree with, but that's not something that I stated.
That,
What in fact I stated was that medical authorities that we generally hold in high regard, particularly these national organizations, are not in the place that you are of introducing legislation to dictate what medical doctors and psychologists and psychiatrists and parents can come together and agree on. That why are we putting ourselves in the place of, in the doctor's office?
yeah, Senator Allred, I didn't mean to put words in your mouth about that you would necessarily agree with me on this, but I think the vast majority of people do feel this way, and I think we'll see that.
Senator Setzler.
Thank you, Madam
you have a
Chair.
Question?
To the author, there are elements of this where there's not good research. The statistic that the likelihood that the increase of suicide rate of transgender young people, I heard 19x more likely to be suicidal. Is that a fairly well-established statistic?
It's a pretty overwhelming number. I don't know the accurate number relating to the increase in depression and anxiety that necessarily would lead to that.
But it is pretty well.
It is
established.
increased, yes.
Increased, yeah.
And again, that goes to why mental health, addressing mental health is certainly the first step.
And isn't it further true, Mr. Chairman, that in the bill debate yesterday about public funding, that the reason there was no action on an amendment was because the existing statute, the existing framework for funding currently funds counseling and mental health care for people that are experiencing gender dysphoria or confusion, and there was no need to add an amendment. Isn't that true?
That is accurate.
Thanks, sir.
Other questions from the committee? Number 4. Okay, go ahead.
To the author of the bill, I missed a little bit of yesterday, but I want to ask a question. I believe over in Houston County, there was a court case that went to the Court of Appeals. And basically it was dealing with denying coverage for gender affirming care to a transgender person because the employee was transgender. Would this bill, how would this bill not incur apply to that case? That case was the case over in, are you familiar with the case of?
I am not
Over in-
familiar with the case, but I think,
It's over
but
in,
this was an adult,
Anna Lane.
correct? This
Yes,
not-
this was an adult.
So no
But-
effect.
but I'm just-
We're puberty blockers,
But
not for minors.
my question is,
Okay.
would this case have any application to say that there was a discriminatory impact upon transgender persons?
No, I mean, I think it's the exact opposite, right? Because you are protecting this minor, as Dr. Zena outlined, the many things that we don't allow minors to do. So this is the do no harm aspect of that.
Okay, I don't see any more questions. So you want to wrap up? We've
Yeah,
got, it's 5:18 and we've got two more bills.
I'm sorry. Thank you. Thank you for the indulgence. I think the aspect is that we have debated this bill. Last year, it passed here, passed in the Senate, and I would look forward for the House to doing that. I mean, I think that, when you look at the accumulation of the data, I think it is the right thing to do, protecting the minors from puberty blockers. And I would ask you for your favorable consideration.
Okay, at this point, I think we don't have any amendments that were submitted. And so I think we're for the sponsor.
And that is, it's my understanding that this bill would cease immediate use of these puberty blockers, and that someone who is in a course of treatment, guided by a medical professional and with the parents, support, that would stop. It would be unlawful going forward when this bill is signed. Is that correct?
So we discussed the provisions in here of how it would be enforced. Physicians, providers would be before the, Georgia Composite State Board of Medical Examiners, and then hospitals or institutions would be through their funding. So that's the enforcement. And yes, to answer your question, when the bill goes into effect, puberty blockers would be stopped. They would be allowed to go through their natural history of going through puberty. That's correct.
So regardless of any medical advice, the care that they're under, the opinion of the parents, all of that is overridden by this bill that you're asking us to pass.
For minors, you're correct.
Uh-huh.
Okay, with that, what's the will of the committee? Is there a second? Second, Dr. Brass? I'm sorry. I didn't hear what you said.
I'll say, I'd like to recognize for a substitute motion.
Yeah. Okay,
I
What's your motion?
I would move do not pass on Senate Bill 30.
okay, we have a motion, do not pass, and an objection to the motion. Sorry, there's a question about whether the motion's in order. so-
Thank you. Letting what?
So the motion do pass is-
A letter from. And she had to do the motion.
That's right.
Is there a second for that? Okay, so all in favor of the do not pass motion, which takes precedence over the do pass motion, raise your hand.
Just the do not pass motion.
Do not pass motion. 1, 2, 3, 4. Okay, all opposed to the do not pass motion, raise your hand. 1, 2, 3, 5, 6, 7. 7 to 4, the motion fails. Now we're going to vote on the do pass motion. So all in favor of the do pass motion, raise your hand. Okay, all opposed? Okay, the motion carries. Thank you. You can take back over up here.
He was counted. He was counted as a do not pass. He raised his hand.
On the do not pass, but on the do
Yeah.
pass, he didn't vote
Oh.
against, he didn't vote against the do pass.
Well, what she announced, I didn't hear.
Okay, yes.
Thank you. All right, if everybody would exit quietly, we sure appreciate that. We have some more legislation. Senator Tillery, we're at you are up. So we're at Senate Bill 91, right?
Yes, sir.
Okay, Senate Bill 91. You had the floor. Thank you.
Thank you, Chairman, members of the committee. Senate Bill 91, you've probably heard some of the arguments from or complaints from independent pharmacies over the years that they feel that they've been paid back less than pharmacies that were not tied into a PBM. Well, what's a PBM? PBM is a pharmacy benefit manager. And due to a lot of the consolidation, I suppose, in healthcare, a lot of the dollars that are spent in healthcare, you've seen pharmacy benefit managers pop up on the scene as long as 20 years ago, maybe a little bit more. And they come in as under the premise of helping manage the pharmacy cost of a healthcare plan. I think that's a good idea as an overall. But what we've seen now is that in some instances, the pharmacy benefit managers have either been bought themselves by other pharmacies or pharmaceutical manufacturers, or the pharmaceutical manufacturers decided that they would get in the PBM market. I don't know which way it was. And what it's created is some type of vertical integration, almost like we saw with Standard Oil or US Steel, or even the Baby Bells that was eventually broke up in the 1980s. Because of that vertical integration, essentially a vertical monopoly, the PBMs end up in a place where they can set the price of the pharmacy, of the actual prescription or the medication at the pharmacy level of who's going to buy it at the retail level, or sorry, the wholesale level. That's that's fine and dandy as too if it's driving down costs for the ultimate consumer. But in situations that we've seen that have been publicized either through social media or heard in our committee rooms, we've ended up at a point where pharmacy benefit managers, at least allegedly, have now priced themselves at a point where they sell to their retail pharmacies at a price that is different than they sell to others who are not a part of their PBM monopoly. I don't think that's right. So what I propose is a very simple bill that says PBMs have a place in the market. We should make sure that that place is honored, and retail pharmacies have a place in the market, and we should make sure that that's honored as well. But we don't need to conflate the two and create a vertical monopoly that sets prices and ultimately hurts not only retail pharmacies, but also at the end, ultimately the consumer. So Senate Bill 91 seeks to break that vertical monopoly and say, hey, you can be a PBM, a pharmacy benefit manager that negotiates prices with retail pharmacies, or you can be a retail pharmacy, but you can't be both. And so that's what Senate Bill 91 does, and happy to take any questions you got.
Thank you, Mr. Chairman. Let's see. Let's do questions from committee for the chairman. Any questions for the Senator Tillery? And you're on number 11?
Number 10.
Number 10.
Thank you, Mr. Chairman. Senator, I'm learning this business as fast as I can, but it seems to me there are three major players that are in the process of bidding on, on our state health plan. I don't know exactly how you call that, but you would know being there in appropriations, and that each of those three have a PBM function, so they're all vertically integrated. If they all decide to continue their vertical integration, then you got nobody left to bid on our state health benefit plan. You're assuming this will force one or more of them to abandon their PBM business?
I'm not trying to force them to abandon their PBM business. I know that we've got three in the state. There may be more, and I'm not trying to help the ones that aren't in the state now. All I'm trying to say is if you've got a vertical monopoly, somebody's getting shafted. So let's take and break the vertical monopoly so that the playing field's fair for everyone.
Can follow up one. So why not just impose a rule that you can't charge more to the independent pharmacies than you charge to your own vertically integrated pharmacy?
Yeah, and I don't know if we would say charge more or you can't charge less. I'm not sure how we would write
Yeah, I
that
don't either.
that bill to be, but that would be another way to tackle it. What we have seen is steering, and that's what the Federal Trade Commission is looking at now. I guess my bill addresses steering by breaking the monopoly, but the Federal Trade Commission in DC is looking at, hey, are these PBMs, these pharmacy benefit managers, steering patients to their pharmacies when the markup is higher? And there is at least analytical data that would show that some drug prices that have been marked up sometimes 16,000% over what's called the NADAC. And I'm learning this NADAC stuff just kind of like you are too. Rather than diving into NADAC and price setting and all that stuff, well, the easiest way to do this is to allow to break the monopoly so that the free market could possibly work. I don't think the free market can work in a monopoly situation.
Any Senator Hatchett?
Thank you, Chairman. Chairman Tillery, last year we had Congressman Buddy Carter come and he was trying to bring something that would deal with PBM transparency. I know we had some other bills that floated around last year trying to address the issues with PBMs. And one of the arguments on the other side was that this doesn't affect independent pharmacies. They're going to be okay. Well, in my district, we've had 3 independent pharmacies close in the past year. One that's been there for 60 years. And the conversations that I'm hearing from my friends are the ones that close, they just cannot compete because they don't have the deals, they don't get the deals. And even if they're paying the same price, they don't get the profits that the PBMs are owned by other bigger pharmacies. Yeah, and I know the larger cities or big pharmacies are, that's the way I like it. In small towns, community pharmacies are kind of the lifeblood.
That's right.
And you can call them on a weekend. It's just, have you worked with the independent pharmacies? Do you think this will be able to address the issues that they have? Because I don't want to see any more close in my district.
As would probably not surprise you, Senator Hatchett, I don't spend a whole lot of time trying to make one side happy over the other. Try to just do what I think is in the middle and fair. And it seems to me that what the fair thing to do would be to just break the vertical monopoly. If that were broken, then we're not setting the price for the independent pharmacy. I'm not even trying to set the price for other PBM pharmacies in amongst themselves. I'm just trying to say if the vertical monopoly is not there, if you're not integrated from manufacturer of the pharmaceutical to pharmacy benefit manager to retail sales, I think the rest of it can take care of itself.
Can I?
Just one follow-up. So your approach would be, this is basically just leveling the playing field.
I think what it's doing is taking the ability, if you own the manufacturer, the middleman, and the sales at the end, then you're able to take and set prices in such a way that you control the market and can run the other business out. I'm just trying to make sure that everyone's fair in their ability to purchase.
Chairman Hostetler.
Mr. Chairman, we've had numerous PBM bills. I'm familiar with this issue. I think this is a good bill that will help level the playing field, and I want to call the question. I would like to make a motion that we do pass Senate Bill 91 by Chairman Tillery, LC 520705.
All right, have a second by second, multiple seconds there. I get it. Okay. Well, so the questions have been called. It's been, got a do pass. And so all those in favor, raise your hand. All those opposed? No, it's not unanimous, but it's close. All right. Okay. Thank you. And I apologize to Jonathan Marquez for not letting you, but you're okay with that, I presume? Yes, sir. Okay. Right. Yeah. You know, my vice chair just left, so okay. So the posture is we have a hearing on the next bill, House Senate Bill 95. I'm sorry, I forgot the dang. Yeah.
Chair recognizes Chairman Watson to present Senate Bill 95. Chairman Watson.
So Senate Bill 95. This is a hearing only. So I think in your folders, you have the original and then you have the substitute. Let me just give you the overview. The overview is that this amends the certificate of need exemption available to life plan communities to allow them to increase their number of beds. A life planning community is those that take you from townhouse or a condominium into maybe assisted living to possibly a skilled nursing home and possibly hospice. So it's the whole gamut there. And that's it in a nutshell. Chairman Brass has been assisting us, and we're working to get that all sides in agreement or at least neutral and working on this to get it done. That's why this is a hearing only. And I agreed to carry the bill from a CON standpoint. You certainly know that we've done CON legislation in the past, and that I agreed to carry it from a standpoint that we can all get all sides in agreement or at least neutral from that standpoint. Mr. Chairman, if it's okay, if we could allow the folks to speak in support and opposition, so we can let the hearing get underway.
You got it. Any real quick questions from members of the committee? Hearing none. Chair would like to recognize some folks who have something to speak. First is Mr. Deke Cateau from AG Roads. Mr. Cateau.
Committee members, by a little bit of background, my name is Deke Cato and I serve as CEO of AG Roads, a 120-year-old nonprofit nursing home organization operating 3 nursing homes here in the Atlanta area. In addition to that, I think I'm qualified to speak to you as a national member of the Board of Leading Age, which is a national organization of almost 6,000 long-term care communities, including life plan communities and nursing homes. And thirdly, I actually very, very honorably represent this state on GARD, which is our Alzheimer's task force. And I similarly do that on a national level as a special government employee. So I know a little bit about our aging population, most of whom are living with dementia, and how these sort of things can affect them. My opposition to it is based on sort of the landscape of our long-term care continuum. I've ran a life plan community in this state already, and they're designed in a certain way for a certain reason. They also take care of a very, very affluent portion of our population. Nothing against affluence. I hope to one day get there and possibly be able to move into one. But that design is also predicated on the opposite end, nursing homes in this state and in many states that take care of a vast majority of people who are on Medicaid, indigent individuals. My home is one of those. Over 80% of who we take care of are indigent. Of that 80%, we lose money every single day on every single one of those indigent people. The way we make up that deficit is by a very small portion of Medicare, particularly Medicare Part A residents. I know you will hear today that in the life plan community and what's proposed, they're talking about a very small number of individuals. But I want to give you a little example to my communities. A small number, I'm giving a number of 2. Should we lose 2 of our capability of taking care of 2 Medicare Part A residents for an entire year for us, that amounts to $500,000 that we would have lost, that we would be in deficit, that with all due respect, the life plan community would be receiving. That affects our ability to take care of those individuals who are on Medicaid. I also want to encourage this committee, I'm so glad that it's not being voted on, is to do a little bit of research into this. I heard the esteemed chairman earlier speak about research in other states related to one of the issues before. Let's see what other states are doing around this. Let's really learn that healthcare landscape, long-term care landscape, which again, I know very, very well. And let's see if the design is not made the way it is for a reason. I also want us to think carefully about what we legislate on today. I would hope we're not making or designing legislation that works today because of the environment today, and we're not thinking long-term of the long-term effects that would have on our healthcare ecosystem, so to speak. I also have here today Pam Clayton, who is with the Georgia Healthcare Association, who I'm sure is available to fill in any gaps in that. But I really want this esteemed group to consider the effect this could have on the most vulnerable in this state, which are those individuals on Medicaid. For me, it's an issue of healthcare equity. We do not want to be a state that is seen as making decisions that favor the most elite in our population. Again, nothing against that. Hope to reach there. And we understand the majority of us in this group that do need appropriate care. And without nursing homes and without that very small percentage of Medicare, we will not be able to appropriately do that.
Mr. Cato, thank you for your presentation. There are questions from members of the committee, and Chair would like to recognize Senator Brass for a question.
Thank you, Mr. Chairman.
What's your number?
Number 11. Thank you, Mr. Chairman. So I'm getting involved to help kind of broker a deal here so everybody can be in agreement or at least close to it. But you mentioned losing 2 Medicaid patients would be about Medicare. Okay, I'm sorry.
Yeah.
All right. That answers my question.
Yeah. Yeah, if it were Medicaid, I certainly would not be here today. And they probably wouldn't be on Medicaid.
Any other questions from members of the committee? Chair recognizes Senator Mangum. Which
I'm trying to get a handle on this matter. The beds are ineligible for Medicaid reimbursement. Why is that important to this bill or fatal to the bill, or why?
So the design in that is based on the predilection that in entering a life plan community, a very exorbitant of money is paid up front to enter these communities. So as part of that, they do not participate in the Medicaid program. They do not. Yes,
So
but
this is only for, so poor people just wouldn't.
no, they're not going to live in these communities.
Chair recognizes Senator Orrock for a question.
Thank you, Mr. Chair. And I enjoy having a Rhodes Nursing Home facility in my district on Boulevard. And they, very familiar with them and highly recommended, have many constituents that have spent their latter years in the care of Rhodes. And I think that the speaker has provided a basic understanding of why we get in and manage, and what the whole point of a certificate of need is that if you strictly let profit making drive the healthcare scene, you will have cherry picking. And in this case, what cherry picking looks like is that these communities that are described here, these life care communities, are expensive, are red carpet, very, the people who are there enjoy them very much and have the money to put into getting into the facility. They have chosen not to accept Medicaid as a form of payment for being there. And Medicaid coverage wouldn't cover the cost of being in that kind of community.
Do you have a question, Senator?
Yeah, I'm explaining the certificate of need, Mr. Chair, and how it works. And so the whole point of the certificate of need means that that facility that plays a vital role with Medicaid clients and a few Medicare clients. Those Medicare clients make the difference in the facility being able to operate.
Subsidize the care.
And have a bottom line that's in the black, not in the red. A bottom line that could be toppled by 2 Medicare patients, clients being if you take apart the certificate of need protection that's there, then they're cherry picked. That's the cherry picking. The people with the Medicare coverage get cherry picked into the facility where that attracts people with the income to afford to be there. And it's lovely. They're lovely facilities. But what happens to the Medicaid patients that are left behind in a nursing home setting that cannot afford the cost? The Medicaid reimbursement does not work. You cannot survive on that alone as a nursing home.
Thank you. We have about a minute and a half left. Chair does have a question. I'm going to recognize Senator Brass. Before I recognize Senator Brass for a second question, I will ask this. The program you provide is a good program. It's desirable. And it's one I think certainly does well to be near the home of folks who are being served. Them being 3 or 4 hours from family members would not be good. Would you agree with that?
Absolutely.
And if this is a system that can support itself financially, and obviously a new facility would not pop up if it couldn't support itself financially. It would be financially viable. That's why they would propose to be somewhere. Why is it that we believe the legislature, by statute, would say to an enterprise, we know you have a business, you're desired by a consumer, you're in a geographic location where it could presumably serve people well near their family members, and it funds itself it's a viable financial model, but we by law and the instrumentalities of the state are going to prevent that from it. Why would we prevent something viable from happening that will serve people well?
I would strongly encourage, again, they do a little bit of research in other states. I would strongly recommend that we do some research again into that payment model of the CCRC of the Lifeline community. I am in no way suggesting that we make these organizations not viable, but I would suggest that their viability does not rely only on the income from that nursing component, which is a very small piece of it. If we look at the entire component and the revenues received from that, I don't think we would be talking about lack of financial viability.
Okay. We're right at 10 minutes. Chairman Brass, One last question, Ben.
Very quick question. Why would a person choose a life plan community over your facility?
For the ability to age in place, for the ability to move into it at a stage in their aging process when they have less need for assistance, and then as they mature, nice way of putting it, as they age, they're able to then move to other levels, assisted living if needed, and if unfortunately needed and have to go to a nursing home, they're right there on one campus having that availability. It's a wonderful model, love it, and like I said, I ran them for years.
So the question before the committee, this wonderful model, should it be limited in how many can proliferate as CON tends to do?
Well, I'm not putting words in anybody's mouth. I'm just asking a simple question. And
But,
he gave me a good answer.
Appreciate your presentation, Mr.
Thank you very much.
We've got 4 people on the opposite side of the question. We're kind of out of the 10 minutes, but we will have a chance to ask the author when we wrap up. That's okay. Mr. Coteau, thank you. I've got 4 people speaking in support. We're going to again manage 10 minutes on either side. I've got 4 names. Mr. Kevin Isaacson is first. On deck circle, Miss Jenny Helms, if you could get ready to go next. Mr. Isaacson.
Thank you, Mr. Chairman. Fellow committee members, I'll be brief. I know this has been a long day. My name is Kevin Isaacson. Our company, Isaacson Living, owns and operates 2 life plan communities, one in Stone Mountain, Georgia, and one in Atlanta, Georgia. In addition, we have done so for approximately the past 25 years. In addition to my company's role, I also serve on Leading Age's board, and I'm also a member of the Georgia Healthcare Association. What our legislation enables communities, life plan communities to do is have the potential to admit some number of people directly into their skilled who aren't residing there as members of the community in either independent living, assisted living, or memory care. This affects 11 life plan communities in the state of Georgia. 4 of those life plan communities are in Atlanta. 7 of those life plan communities are in other cities, such as Athens, Columbus, Gainesville, Macon, Noonan, Rome, and Savannah. And today you're going to hear from a couple operators of those communities. On average, among those 11 life plan communities, each has 37 licensed skilled beds. Those skilled beds, as required by the Department of Insurance, which is the primary regulatory body of a life plan community, are actuarially based to support their existing membership in independent living, assisted living, memory care. That is our goal. That is our objective. Average number of beds, 37 of 11 communities. That's 411 total beds. Those 411 total beds, total skilled beds as part of a life plan community are there primarily to support the members who already reside at a life plan community. On average, and so of that 411 bed, just as a point of comparison, is a little less than 1% of the total number of licensed skilled beds in the state of Georgia. There are over 40,000 licensed skilled beds in the state of Georgia. As part of a life plan, as part of one of the life plan communities, the 11 life plan communities that would be affected by this legislation, there are 411, a little less than 1%. When you look at national averages, national occupancy averages, and I expect the state averages to be higher than this, but the best I could pull in advance of today's meeting was a national average. Life plan or skilled beds as part of life plan community maintain an occupancy of 72%, supporting their own internal members on average. I believe them to be higher in the state. We've experienced that at our own properties. So when you're looking at the potential impact on 411 skilled beds, those beds are predominantly, in fact, 75%, almost 75% of them are supported by their own members residing on property. So ultimately what this legislation is seeking is to potentially allow for, call it 100 beds in the state of Georgia as part of a life plan community to have the opportunity to admit somebody directly in from the outside, keeping in mind that we do not accept Medicaid. And I would like to just clarify, we're not, again, the primary regulatory body for us is the Department of Insurance, and us obtaining a certificate of authority, which allows us to develop and market ourselves as a life plan community. in obtaining that certificate of authority through the State Insurance Commission, as by law, we cannot accept Medicaid. As by law, we cannot accept Medicaid. So that's I just want to clarify why that's there. So with that, I know we have other speakers, but I just want to emphasize what ultimately this has the potential to affect is 0.005% of the total skilled beds in the state of Georgia, So with that, I'll yield. Thank you.
Thank you, Mr. Isaacson. Next, Ms. Jenny Helms, and on deck is Cameron Honeycutt. So get ready if you could stand.
Mr. Chairman, members of the committee, I'm Jenny Helms, president of Leading Age Georgia. We represent the continuum of care, and our Life Plan community members came to us and asked us to support this. The main reason that most of our members want it is that they have people come to them in their communities who want their spouses or their parents to be able to live in the Life Plan communities right around where they live. And that's the reason that we came before it. I did hear Deke Cato loud and clear, and I'm a huge fan of AG Rhodes. And I think that maybe we should sit down at the table and negotiate. I'm excited that Senator Brass is willing to talk about that, and I think we need to do that. AG Rhodes serves a great population. But I will say that I do think that when I hear the argument that they need the private pay, that I think it reflects that the Medicaid rate doesn't pay for what we're trying to provide the care for older adults. And I think that the reality is that at least 70% of Georgians are on Medicaid in nursing homes, because while you might go in with plenty of money, you run out. And so I think that while we're looking at this, we all have to think really hard about paying for what it really costs to provide quality care. Thank you.
Any questions? Seeing none. Next, Cameron Honeycutt, Presbyterian Homes of Georgia. Cameron.
Chairman of the committee, thank you again for having me. I won't go through some of the redundancy that's been hit by Kevin, but of the 11 Lakeland communities, the majority of those are nonprofit entities. I'm a nonprofit entity as well. The one I'm speaking to is in the Athens market, is 4 years old. A lot of these people that are coming in with private money, they go through those assets, they may get to a point that they don't have enough to live off on. It happens, and when we come through and subsidize that care through our foundations, a lot of these other companies have that as well. So I just want to make it a point that of the 11, let's see, 7, 8, 9 of those are nonprofit entities with foundations that bolster that effort as folks go through this. I met with a family yesterday who had shopped the Athens market, and basically their private pay, and this is where my mind goes, is she was looking for a place for her mother. She had been through all the other facilities in the Athens market, and there were 4, we were the 5th one, and she was thankful to be there, obviously, to have that experience. So we want freedom of choice, ultimately, in this conversation. That's the big proponent is, as all of us are making these decisions, as we're 65 and older, we need skilled nursing services. It's more of a freedom of choice element in this consideration. So with that, I yield my time.
Any questions? Seeing none. Last, we have Mr. Michael Berry from Wesley Woods. Mr. Berry.
Thank you, members of the committee. I'm Michael Berry. I have been a skilled nursing home administrator for over almost 20 years now, and in the Life Plan community for just under a year. Transferred over to the Life Plan community here in Wesley Woods, Noonan. And I'm in support of this proposed change to the CON. Just to piggyback off of some of the comments that have been made, my clientele are aging in place, definitely, Deke, and they are waiting until the very end to go to the skills side. At that point, they have gone through all their money. They don't have any money anymore. Right now, they would qualify for Medicaid, but they don't, because the families pick up the tab for them going into the skilled care. And then our foundation subsidizes and pays for their skilled care stay. I just want to say, in this past year, 35% of our inquiries or referrals have been from people that have not started out at the occupancy entrance level fee. They're just wanting to come in and do a short-term stay for subacute rehab, or for a hospice respite stay. And that's a disservice to the folks in Coweta County, that 35% of them are wanting to come to Wesley Woods. They prefer, that we're a preferred provider, but we cannot provide that service because the CON limitations. I would ask the committee to explore it more and support the change. Thank you for your time.
I've got a question for you. Are there any questions from members of the committee before Mr. Berry steps down? Mr. Berry, question for you. We talked about the amount of funds that come from Medicaid versus Medicare and other private pay and private pay enhancements. Do you believe that, is what we're hearing, the government's willing to pay a certain level of funding for Medicaid when people don't have their own assets, which is a level of safety, decency, dignity, but maybe less than the highest level of services and comfort perhaps that can be provided on top of that? Is that kind of where Medicaid is? And what you're saying is if people have their own assets they want to bring to bear to pay on top of that and have more luxuries, as it were, there shouldn't be a CON system that prevents that from being in existence just because of the CON administration's view of kind of market saturation. What's your take on that?
My take on that is that Medicaid obviously is means tested. You have to meet that means test to qualify for it. Then you got people that are in the middle income market that make too much money to qualify for Medicaid and maybe not make enough money to qualify for a life plan community. But if they invested appropriately, they could definitely qualify for a life plan community, but their assets are going to prevent them from use Medicaid in other traditional skill settings. But they would qualify to come to the life plan community under the plan if the CON was changed.
Thank you. Any questions for Mr. Berry? Seeing none, thank you.
Thank you.
I'm going to recognize the bill's author. I know this is a hearing only today. Let Chairman Watson speak to this. Do any members of the committee have questions for Chairman Watson? Chair recognizes the senator from the 9th.
Yeah, so my concern about this bill is, won't it be hard for Medicaid patients to even have a bed if we, under this bill?
Thank you.
That's my first.
I mean, the bill,
Then I have a,
I mean, what the bill does is allow an institution that does not, that cannot by law accept Medicaid patients.
I got that.
And so it expands that. So it is for people who have, the life care community, generally is for higher income, folks. There's no doubt
And
about that.
That's my concern. So it's going to almost block out Medicaid patients. They won't have a bed. It's going to be in favor of the life care.
So
I'm sorry.
I don't think those patients, I think that were in the skilled nursing facility, it's a question of whether or not those two Medicare patients are going to life plan communities. So they're only a very small percentage of beds allowed even in the state of Georgia for these, compared to the whole big picture. The life plan community probably could answer that better than I, but we are going to continue to work on this.
Okay, and my follow-up question is, where in this bill, does the language limit the number of people exempted in con nursing home beds? Let me answer again.
Yeah.
Where in this proposed bill is there language that limits the number of people exempted into the con nursing home beds?
Can you help? I'm not sure exactly what you're asking there.
So I'm looking for, is there anywhere in here that would exempt the number of people that are in the con nursing home? Is there any limited number?
So you're talking about the
Nice.
nursing home, do skilled nursing facilities have a CON limit? Is that
Right.
what you're asking?
Yes.
Yes, that's already existing.
Okay, so Yeah, and I know con is certificate of need, is, y'all understood what I was saying. So where in this bill does it limit the existing life plan community people?
Currently limits it now.
Is there, again, I don't want to get too far afield. Is there anybody that can specifically address the senator's question?
But the bill doesn't limit it.
You want to come up?
I'll recognize you at the podium. Yes, sir.
The existing law limits it by year 5. You cannot accept anybody from outside the community into a skilled nursing setting. Does that clarify?
Have someone that can answer.
Because again, after year 5, the skilled nursing setting's intended to be sort of the next step in care for those who are actually within the community. So there's.
So, so it would be considered self-feeding from those who live in the community. As opposed to what we're talking about now.
The answer to your question, according to our legal counsel's line 25.
Yep. So
We're striking that.
So
So we're-
Chairman Watson, do you want to speak to that at all? Again, I don't want to get
We're
back to
striking that line.
start recognizing folks again. One of the reasons we're doing hearing only today is we can sort of unpack the issues and sort of have a to-do list of things to go figure out before the next hearing.
That you're deleting that limitation. That line is
That's
being
where it
stricken.
is. And that's accurate.
So Chairman Watson, are there any other folks you'd like to, as part of your wrap
Well,
up,
you
you'd
know-
like to speak to this?
Again, I'm not carrying the bill unless we have agreement and we can work out the details.
I don't want to truncate any discussion. Is there anyone else you'd like to, if we've got 5 or so more minutes, could you shed some light on this, please?
Yeah, thank you so much. And I will be brief. Pam Clayton with the Georgia Healthcare Association. I appreciate the opportunity just to kind of fill in just a little bit of a color here. And so in the bill, it does not limit the number of beds that the life plan community could allow to serve in the skilled nursing facility. And I think you ask a question about why should a private enterprise be required to limit the number of people that they serve if they're paying from a private pay standpoint. But if you think about the CON construct that we currently function in under, it serves to ensure that there is adequate capacity to provide access to care to meet the healthcare needs of Georgia's elders or others, and that the service model would be intact and be there to meet those needs. And there is not a demonstrated capacity need at present. And so you're contemplating removing a certificate of need exemption that already exists for life plan communities and removing any constraint upon that. And yet the skilled nursing facilities would continue to have to function within the constraints of the CON process. And so I think that certainly we respect the service that the life plan care community offers. There was language that put in place to allow for external admissions for a period of time when the life plan community opens, and that being for 5 years from the date of opening. And at this point in time, there is not, from a CON standpoint, a demonstrated gap in need.
So sounds like there's some room for, there's some work to do.
Yep. So appreciate your presentation. With that, gonna give the author final word. Anything, Mr. Chairman?
We're going to work on it offline and bring it back when we have an agreement. Thank you.
I'd like to thank everybody for being here today. We stand adjourned.